Next, we call upon Jibia, evaluation of immunogenicity of SARS-CoV vaccine in kidney transplantation recipients, a single center study.
Good morning, everyone. I'm Dr. Jibia, DM resident from Institute of Nephrology, Madras Medical College. I'm presenting my study, the evaluation of immunogenicity of SARS-CoV-2 vaccine in kidney transplant recipients, a single center experience. So the background of this study, as we all know, the COVID-19 pandemic has resulted in tremendous morbidity and mortality globally. Though renal transplant recipients represent a high-risk population, they were grossly underrepresented in COVID vaccination trials. So we studied the seroconversion rates of kidney transplant recipients who are vaccinated with COVID-19 vaccine, either Covaxin or Covishield. So the aim of the study was to determine the immunogenicity of COVID vaccine in kidney transplant recipients, and the objectives were to measure antibody titers to spike protein 4 weeks post second dose of vaccination and to assess the relationship between antibody titers and comorbidities. So methodology, it was a prospective observational study. The study period was for a period of 6 months from April 2021 to September 2021. It was conducted at Madras Medical College and it was a pilot study. The study population were the transplant recipient followed up in nephrology outpatient department. So the inclusion criteria were all kidney transplant recipients who were willing to take part in the study, and the exclusion criteria were recent transplant recipients within a period of 6 months, patients who have received anti-rejection therapy within a period of less than 1 month, and patients who had active COVID infection. So coming to the procedure, the following data were collected from the selected patients by accessing the medical case records, the demographic data, medical history, number of years post-transplant, the maintenance immunosuppression which were used, and prior history of COVID infection. All these were collected. Informed consent was obtained from all patients. And 2 doses of COVID vaccination, either Covaxin or Covishield, were administered intramuscularly 4 weeks apart for Covaxin and 6 to 8 weeks apart for Covishield as per the government regulations. And blood samples were tested for antibodies to the S1 domain of SARS-CoV-2 spike protein at the baseline and 4 weeks after the second dose by the electrochemiluminescence assay. So these were taken as the cutoff as per the manufacturer's label. Less than 0.8 unit per ml was considered negative, 0.8 to 250 unit per ml was considered as average response, and more than 250 unit per ml was considered as robust response. So appropriate statistical analysis were used, and p-value of less than 0.05 was considered to be statistically significant. So coming to the results, the second column actually represents the overall population. The study population was 150. The third column, we tried studying between the 2 groups of vaccine, that is Covaxin and the Covishield group. Coming to the baseline characteristic, predominantly it was the male population. Among 150, 116 were men. Median age in years was 40 years, and the median baseline serum creatinine was 1.3 milligram per deciliter. Predominantly, they were living donors. 104 among 150 received a live-related transplant, and 46 received a deceased donor transplant. And the median time since transplant was 6 years. 39 patients had history of diabetes, including post-transplant diabetes, and 71 had history of hypertension. Only 18 patients had documented prior COVID-19 infection. Coming to the immunosuppression, 114 patients were on MMF, 21 on AZA, 109 on tacrolimus, 31 on cyclosporin. All patients were on steroids, and the standard triple immunosuppression was used in 104 patients. So coming to the baseline titers, among the 150 patients, 95 patients were already seropositive. They had titers more than 0.8, among which 56 had average titers, and 39 already had robust titers at the start of the study. This is the antibody titers which was measured 4 weeks after the second dose. So the first set is the serological status at 4 weeks after the second dose of vaccine. Among 150, 114 were seropositive after 4 weeks, and 36 were seronegative at the end of 4 weeks after vaccination. And we tried studying a separate subgroup, that is 55 patients were seronegative at the baseline. So among them, we tried studying how much turned positive. So at the end of 4 weeks, only 19 patients turned seropositive among the 55, and 36 patients turned 36 continued to be seronegative at the end of 4 weeks after vaccination. We tried seeing if there was any difference between Covaxin and the Covishield group, but then there was no statistically significant difference. So this is the flowchart which shows the vaccine responsiveness among the transplant recipient. Overall, it was 150 population, among which baseline seropositivity was seen in 95 patients and 55 were negative. Among the 95 seropositive patients, average response was seen in 56 and robust response was seen in 39. Among who were baseline seronegative, after 2 doses of vaccine, only 19 patients turned seropositive, that is 34.5%, which actually shows the true immunogenicity of the vaccine in this study population. And 36 patients, they continue to be seronegative after 2 doses, that is 65.4%. Among patients who turned seropositive, again there is a glaring difference that all patients, 84.2% had an average response, whereas only 3 patients, that is 15.7%, mounted a robust response. We tried seeing if there was any factors that influence the responsiveness of the vaccine, like age, sex of the patient, diabetes, hypertension, graft dysfunction, type of the vaccine used, and then the type of transplant, time since the transplant, the immunosuppression used, and the documented prior infection, but we could not find any statistical significance with any of these factors. So coming to the discussion, a significant number had baseline seropositivity despite not having a prior COVID-19 infection, indicating a subclinical infection. More robust response in baseline seropositive transplant patients compared to robust response in baseline seronegative kidney transplant recipients. This may be due to a pre-existing B-cell memory in COVID-recovered individuals. And the seroconversion rate among those who were seronegative at baseline was only 34.5%, which is consistent with other literature. No significant difference in vaccine responsiveness was noted between both the vaccines in our study. Advanced age, use of MMF, chronic graft dysfunction were attributed as predictors in other studies, but we were unable to identify any predictors of vaccine responsiveness. The strength of the study, baseline titers were checked, thus immune responsiveness to prior infection could not be attributed to vaccination. The limitation is a significant baseline seropositivity at the start of the study. Conclusion, there is a high prevalence of baseline seropositivity among transplant patients. Baseline seronegative patients had a seroconversion rate of 34.5%. Transplant-related factors with respect to seroconversion were studied, but none were statistically significant. Monitoring antibody titers and administering booster doses might help in this high-risk patient group. Thank you.
It was very good, well done study.
Thank
you. It is a surprise that even among transplant patients you had a baseline, even without a COVID infection, you had such a lot of number who had seropositivity.
Yes, ma'am.
Right? And you said booster dose. Out of the study, did you put some people on booster dose and then check their titers later on?
We had actually planned, ma'am, but then we could not do the study.
No, not as a part of the study,
Okay.
but have you done that?
No, we have not checked the titers. We have encouraged patients to take booster doses, but we have not checked the titers after.
That is very interesting.
Also, why I think after 2 doses, I think only 19 actually had this thing, conversion. Is it only because all of them got vaccinated after 6 months only? So you expect at least some more seroconversion to happen?
I didn't get the question.
So actually the numbers of seroconversion after giving 2 doses of vaccine was still less.
Yes, ma'am.
Is it only because of the immunosuppression which was still in them, or because the duration of 6 months have already passed by?
Yes,
so you have almost got all the doses at a lowest level. Despite that, your seroconversion rates were not good.
Yes, ma'am. We tried studying the literature. In other studies, they have said the use of MMF, use of the triple immunosuppressant, they've all played a part. But when we tried analyzing, we could not find even that as a risk factor. Whether they were on MMF or not on MMF, some have seroconverted and some did not. We could not find an exact reason why certain people did not seroconvert.
Okay.
What is the TAC levels that you keep for these patients, or CNI levels?
Ma'am, after 1 year, it's around 5, ma'am. In our institute, it's only around 5.
TAC.
TAC level
Yours
is
is
around 5.
predominantly TAC.
Yes, ma'am, we use
Other,
TAC.
I mean, cyclosporin you have not used.
Predominantly is tacrolimus, ma'am, in our institute.
Okay. Good.
Thank you.
Thank you.